introduce her, and she said no hyperbole, just the facts. The problem is there are no facts about Dr. Macklin that would not sound like hyperbole to anybody else. So this is all true. She is, and I'm not going to even read the bio. What you need to know is that Dr. Macklin is one of the most distinguished philosophers in the field of bioethics who has accomplished and contributed more than just about, at least as much, let's put it that way, as anybody else has contributed to our knowledge base and also to our ability to translate what we do as scholars in bioethics to what actually happens in practice and in practice around the world. There is probably no one who has clocked in as many miles, maybe 20 in second, but Ruth has clocked in probably more miles than anyone, traveling all corners of the globe, trying to understand what the questions are that matter to people who are wanting to do the best possible research in the most ethically acceptable fashion. She has turned some of that extraordinary talent and experience and energy to looking at questions in particular that are raised in the context of research and disasters, and it's to that that we're going to be treated today. So please join me in welcoming the distinguished Ruth Macklin.
Thank you very much, Ruth. I said no hyperbole.
There was none.
But it was truthful about those miles. Last week it was a 24-hour trip from Taipei, and it almost violated my rule, don't spend more time in the air than on the ground. So I'm going to be talking about research and disasters, and the secondary topic, as part of that topic, is on vulnerability and vulnerable populations in the context of research and disasters. So the first point, and some of this is going to be very obvious, how many people here have ever done research in disasters? Okay, a couple of people. So you can correct any false statements that I may make, or perhaps add to it in the discussion period. The first is that point, and I think this is intuitive, is disasters create vulnerability. Even if you have a population that is not otherwise vulnerable in one of the many ways that I'll be discussing, people are rendered vulnerable by injuries that they may suffer, by fear in the midst of a disaster, or if one is coming, or even in the aftermath, such as the possibility of aftershocks in an earthquake. Grief, because very often in these disasters, even if one is not injured or injured only slightly, there may be family members, neighbors, and others who are maybe seriously injured or even killed in the disaster. Inadequate food and water, depending upon the nature of the disaster, where it occurs and what the resources are. Loss of housing. Whenever you see those pictures, you see people standing in front of their crumbled house. Disease outbreaks, and I'm going to say a little bit more about that, because that can happen also in a disaster. And this was an interesting case, an interesting example. The cholera epidemic that occurred in Haiti following the earthquake. Haiti had not had any cholera. This was not an area that was endemic to cholera, and so in the past, there was no cholera. But it was, I guess, believed and then later documented that it was some of the rescue workers who came from Nepal who actually brought the epidemic of cholera. So this was not a naturally occurring cholera following the disaster, which does occur in some places, but it was sadly the result of rescue efforts and people who came from outside. So that's among the kinds of vulnerability that are created in a disaster. This is, the CDC. Here is Haiti after the earthquake. And you can see, as we'll see some more pictures, a few more pictures later, that there's usually a great deal of chaos in these situations, even with humanitarian workers, and even, as we'll see later in Japan, which is an industrialized country with resources that these disasters create havoc. Well, in some cases, populations are vulnerable before a disaster. There may be an area in which there's food insecurity. Haiti is one example of that. Lack of potable water, which may occur in a variety of places, either because of drought or because of a poor water supply. inadequate health care, mostly in developing countries, but could happen, as we know, in our own country, in some parts of this country, and that, I think the example there was in Hurricane Katrina, which we had an example in a poor area of our own country. At risk from endemic diseases, that is, diseases that might be there anyway, places that might have cholera or any other disease where people are at risk. So people may be vulnerable before the disaster, and so what we can see here is the possible compounding of vulnerability during and after a disaster. Well, let's get to the question of conducting research in disasters. There are a number of criticisms that actually occur in the literature on this, and then there are those that we could think of. And if this were a smaller group, I would invite the audience to think of some examples of criticisms or what you might think is critical of a disaster, but in order to get through the slides, and we'll have some time at the end for discussion. So one claim that is made, or that might be made, is disaster victims are rendered too vulnerable by the disaster to ask them to participate in research. Well, the trouble with a statement like this is it does not identify the characteristics of vulnerability that might create an ethical problem in inviting people. So one has to go deeper than just making a sweeping claim about vulnerability. A second claim is you already have in developing countries or in a developing portion of our own country, like New Orleans, a poor area of New Orleans, poor communities, they're already vulnerable by virtue of being in a resource-poor environment, and now you're compounding that. The disaster actually compounds that, so this is too much vulnerability to do research. So, like the first criticism, it doesn't specify what the characteristics are or what the criteria for vulnerability are that would militate against the conduct of research. And of course, one claim is they need aid, not research. And if you start, well, let's see if I have this slide here. They need aid, not research. I mean, because the research may not benefit them. The aid, arguably, is designed to benefit them. And the related criticism here is any efforts to conduct research might actually take away from the efforts, the aid efforts. So we'll come back to that point as well. Now we have the well-known therapeutic misconception. I was at a conference on ethics in disasters, and one person referred to this as the philanthropic misconception. That is, the misconception that the people who are there to provide, that people who are going to conduct research can be confused with those who are there strictly to provide aid. And of course, there are some groups that do both. The International Red Cross provides aid. MSF, Médecins Sans Frontières, does both. They both do research and they provide humanitarian aid. So it might be natural to confuse the role, and especially in places where a white coat or having a stethoscope or drawing blood, for example, it would be natural, especially if there are populations who are not familiar with the research enterprise. And then there's the argument about instability, and this goes to the question of the ability to provide informed consent. So this is the first comment or criticism of research involving in disasters that mentions a criterion or a characteristic, namely an impaired or weakened or not total inability, or in some cases it might be a total inability, but this goes to the question of the requirement for informed consent in research. So this specifies a little more closely than the general sweeping claims about emotional instability. Well, even following a disaster, that is when it's no longer, the event is no longer occurring, some people claim that victims may be traumatized even if you're doing something as presumably non-invasive, like an interview, or even a routine physical exam, one that may not be especially invasive, but a routine physical exam. The trauma from the research itself, from the activity, the disaster, followed by an interview that may remind them of the horrible circumstances that they went through. So the recall, this is raised in other contexts as well. For example, when people do research in especially sensitive areas, such as abuse as a child or sexual abuse, researchers worry, or ethics committees worry, that you're now going to make people relive a horrible experience, and that is could cause psychological harm. And of course, this is one of the biggest worries, that conducting research may impede efforts to mitigate harm. And this is the argument that all of the resources and all of the personnel should be devoted to providing the necessary aid and minimizing the harm, or at least treating harms or injuries that have already occurred. So research can interfere with that. It can intrude into rescue operations. And now we get to a different point. If you're going to conduct research, one of the cardinal requirements internationally, as well as in any place research is done, is the need to have prior review by a research ethics committee. So if you have a disaster, how are you going to develop what is a research protocol? How many people here serve on IRBs or submit protocols to IRBs? Okay, so you know about how time-consuming it may be, how detailed it may be, how many revisions you may be asked to make, sometimes the time about which researchers complain about. This is a process that can be onerous for the researchers, and certainly has to be done with all of the dedication and devotion by the Research Ethics Committee, or the IRBs, we call them here in the United States. So you can't just slap something together. If you slap something together, in general, the committee will know and recognize that and tell you, say, come back with a real protocol. So this now is a barrier that has nothing to do with the vulnerability and everything to do with the requirements for conducting research. And the consequence, I mean, this is not only a procedural requirement, but obviously there's an ethical foundation to this requirement. It's not just that you have to go through these procedures because the feds tell you to, or OHRP is going to be breathing down your neck, which I think happened here once or twice. But research subjects themselves, the whole point of the Research Ethics Committee is to devise appropriate protections for the rights and welfare of the research participants. Even though it's probably true that most research ethics committees have not had experience with situations in a disaster, but you work by analogy with any other situation. So this was those floods that they had there in Australia, and I didn't label the other photo, which I was remiss, because you're always supposed to label your photos and say where they come from, but this one is the Australian Broadcasting Corporation. It's just a reminder that a picture is worth, is it 1,000 words or 10,000 words? Something like that. So, everybody know what this is? Here's Japan. It's radiation. Now, why do we need research? I'm sure there are people in this audience who can both more elaborately and more scientifically give some examples of things that have to be studied that could only be studied in the course of or immediate aftermath of a disaster. The only example that I did some research on for this presentation is on the question of radiation. So according to one article that I read in the literature, and again, I don't footnote the slides, but I can just assure you this came from some article or other that I have on my computer, that in today's world, for reasons we all know, there is an enhanced likelihood of accidental radiation exposure, more so than any time in the past. An increasing use of nuclear technology in power production, and the possibility of nuclear terrorism or war. And the article from which I took this particular piece of information was written before the earthquake in Japan. So this was clearly something that was a little bit prescient on the part of the author in mentioning the nuclear technology, which in Japan, of course, there's a lot. Well, why do we need research on radiation? And this is clear that it's something that could only be done during or immediately after some kind of exposure, accidental exposure. And there are gaps in scientific understanding. And one reason for this is, obviously, it would be clearly unethical to go around intentionally exposing people to a whole lot of radiation to see what happens. Ruth Faden was the chair of the Advisory Committee on Human Radiation Experiments, and I was fortunate enough to have been a member of that committee, and we did see some examples of intentional exposure to people of radiation during that era in the United States. But in general, and especially because we wrote a report that Jeremy Sugarman worked on and Jeff Kahn worked on, the report made it clear that these are no-nos. You can't start exposing people to plutonium without telling them that you're injecting plutonium into them. So, therefore, if we want to learn more about radiation, which is needed for to fill a lot of gaps in understanding, one would have to do this kind of research. One of the items here is different dose ranges and post-irradiation windows. Now, with drugs, it always struck me in phase 1 studies, even though one of the rules of research ethics is to minimize risks to participants, when you have dose escalation studies, you're actually maximizing the risks up to a certain point. You're not, you stop at a certain point. But a dose-finding study, a dose escalation study, is anything but minimizing risks. But of course, you have to know when to stop, and you have the appropriate rescue. So here, different dose ranges of radiation, a fair amount is known about this, and has to be in any kind of research protocol that involves radiation. But there are a number of other variables. So one argument is that this would help in improving therapeutic approaches, namely knowing what doses people have exposed to and then what kind of treatment is desirable after such an exposure. And here, so I knew nothing about this. I knew that there were problems, but I knew nothing about this particular difference. The expected health consequences for a victim of the Chernobyl accident would be different from the health consequences from those who were exposed to the atomic bomb dropped in Nagasaki and Hiroshima. And the difference there is the difference between external whole body radiation versus exposure from the fallout of radioisotopes. So presumably you need to know both if you are dealing with a population that's been exposed, because these are two different types of exposure, and they may have different health consequences, including different long-term health consequences. So in the the tsunami, the post-disaster situation provided an opportunity for needed research. And remember, this was a triple disaster. It started with the earthquake, followed by the tsunami, followed by the nuclear plant. So if there ever was a vulnerable population that was probably not particularly vulnerable before the research, this is probably one of the best examples because of the water supply and everything, then the radiation and everything that followed. It's always interesting when you find scientists disagree, because people think, oh, it's only you ethicists who disagree. But actually, scientists disagree even when there is adequate information or research, and it remains true that experts disagree or claim that there's a lack of sufficient knowledge of the health effects of low-level radiation. And this is true actually within the medical profession too. I have colleagues who come and ask about various exposures and actually claim that they have other colleagues who disagree with what they consider to be the acceptable level. Knowledge is lacking about the extended periods of time during which one might be exposed to radiation, and especially needed for decisions regarding children, because of course, as everybody knows, children are not just little adults, and one needs any kind of information specific to children, which is why we now have mandated studies. After years of saying don't do any research on children because it's not ethically acceptable, now we have requirements to do research on children. And in fact, among the experts in Japan, they could not agree, this was immediately afterwards, on the numerical levels of radiation for deciding which areas are safe to inhabit. And if we add to that what we've read in the newspapers, I only know that account from the New York Times, but as we've read in the newspapers, there was also some attempts on the part of the government to suppress information, or at least not to disclose information, and every government in the world is keeping secrets about anything they can keep secrets about. So this is a problem if it's not only the government keeping secrets or failing to get full disclosure, but when the experts disagree, one can't even have somebody come forward and try to thwart the government's attempts at secrecy. And in this case, the dispersal of radioactive material was much longer than at Chernobyl. So this is just a kind of justification, and this is only the example of radiation, of why it's necessary and desirable for scientific information and for therapeutic benefit to do research. And of course, if it's a longitudinal study, that could take decades. And one doesn't know who's committing those resources to longitudinal studies, but of course we also always know that the longer term, the earlier at which one is exposed to radiation, the greater the likelihood that cancer will develop later on, because it's a longer, people live longer. Here's one other example. Yeah, this came up at a conference that I was at. This is interesting to me, and again, people here I'm sure know more about this than I. Open limb fractures, a common injury in disasters such as earthquakes. And if it's a big fracture and it's an open limb fracture, this would be typically lethal if it were not treated. The ideal treatment, and then I had to look this up to see what it was like, and I saw some of these contraptions that they use for surgical fixation. The ideal treatment is a surgical fixation following a recovery period. That's ideal. However, we're talking about a disaster here, and earthquakes, and no equipment right there on the field in the area. So the quickest, the most efficient, which for some people is important, the cheapest, which for many people is important, but the most likely to save life would be immediate amputation. So here we have two different methods of treating an open limb fracture. And the question then arises, would a randomized trial be ethically acceptable? I see people smiling here. And obviously, how one would do a randomized trial in these circumstances, even if you had the equipment, raises an important question here. So the one obvious problem with the randomization is inability to have informed consent about which treatment you would get. In randomization, obviously, the subjects are masked, and there might be people who say, yes, save my life with the amputation, and others who say, save my leg with the surgical fixation. If you were in a clinical context, obviously, they would be given that choice. But if you're going to randomize in a field situation when people are traumatized, they wouldn't have the choice. So would it be ethically acceptable to do that kind of research? I'm not going to give answers to all these things, but merely, provoke a few thoughts about it. And then the question, always the response is, well, it would be unethical to randomize because of X, Y, Z, because people have preferences, and there are plenty of studies that I've seen on IRBs that are not randomized. Nevertheless, the purists, the methodological purists, are going to argue, these are the orthodoxists are going to say you're going to introduce bias unless you randomize. So here we have the traditional dilemma of the gold standard in ethics being properly informed consent, and the gold standard in clinical research methodology with a tension between them. I don't want to say it's a sharp clash, but there's at least a tension between the two. And then, of course, on the consent question, would the consent that you are obtaining in that situation, if it would not be methodologically prohibited or forbidden on the grounds that the methodologists say for some reason you're not going to get accurate results, what are people giving consent for? Would it be for the treatment itself or for the research? Well, arguably it's for both, but it's one thing when people are in need of immediate treatment, and this is no different from the clinical setting, actually, when you're asking them to consent for a procedure, but then you have to start explaining what research is and what the procedures are and the risks and benefits and the alternatives, et cetera. So this is a little problematic if we're thinking here about an urgent situation or even one that's an emergency if you have, we're talking now about open limb fractures as the example. Well, here's another topic, very different actually, and this was a little surprise to me, although it should not have been, knowing about all the things that are not known about research involving women. The World Health Organization says there's a general lack of research on sex and gender differences in vulnerability to and impact of disasters. So I was actually somewhat surprised to come across this because this is a very specific topic. We're talking about research during disasters and women during disasters. So there is evidence that you can find on the WHO website of greater vulnerability of women than men when disasters strike. Now, why should that be? Well, for one thing, again, one of the horrors that we know and read almost every day, yesterday's New York Times, women and girls are more vulnerable to sexual abuse in disaster situations. You've got internally displaced persons. You have refugee camps. You have crowded situations and circumstances, and not homes where there are even parents in some cases to care for them. So this is apparently a phenomenon not only in disasters but in lots of other situations like that of wars and conflicts of various sorts. And again, I'm making this up. The WHO has discovered that the sex industry often becomes part of the interaction between refugee or displaced populations and the local community. So this is an example. If we ever had an example where we don't have to define what exploitation is, this is the example of you know it when you see it. There's been a lot of literature on exploitation, and people have different definitions and different debates about it, but I think all one has to do here is define what is intuitively obvious about this being exploitation. One example that I came across, just very quickly, it's not only sexual abuse and the sex industry. Why is it that women are more vulnerable? Well, a couple of examples came from observations of what followed certain disasters. Men were working in the fields, women were in the homes collapsed, and the women were killed because they were indoors, and the men were not harmed because they were outdoors and nothing fell on them. The sons were away at school in some other city, and so they were safe from the immediate disaster, but the daughters were in the homes with the mothers because in these countries they often don't educate the girl children. So that's just one example. I mean, the example of the sexual abuse is a different kind of example, but even in the nature of the case, if you're indoors, you're more vulnerable than if you're outdoors, apparently. All right, now the justification. I should have quoted the School of Public Health here, but I didn't find a quotation for that. So the UNC School of Public Health says, to ensure effective and equitable, there's the ethics aspect of it, to ensure effective and equitable responses to future disasters, we need to study what works and what doesn't work in present disasters. It's quite clear. It's like justification for any research, right? Well, this is true, but then, of course, the need arises or exists to devote attention to the ethical concerns that I've just reviewed in the criticisms of doing the research in disasters. So the basic threshold question is, are victims of disasters too vulnerable to permit their inclusion in research? And if that's a basic question about the ethics of doing research in disasters, then we have to know not only who is vulnerable, but why are they vulnerable, which will take us into a little bit of a conceptual inquiry into vulnerability. So I hope this is not too theoretical. Well, let's see what they say in the United States first. Let's look at what people say about vulnerable subjects. OHRP, our favorite oversight organization, refers to vulnerable subjects. But the federal regulations do not use the term. The word vulnerable appears nowhere in the U.S. Code of Federal Regulations. Subparts B, C, and D, as we know, require additional protections for fetuses, pregnant women, prisoners, and children. So by implication, not by identification, but by implication, whenever a population is thought to be a vulnerable population, that gives rise to the need for, sometimes it's referred to as special protection, sometimes additional safeguards. So this is the additional protections for fetuses, pregnant women, prisoners, and children, and that's all. Now, we're going to contrast this. These are the only populations, according to our enlightened US federal regulations, to which special protections apply. So let's see what some other documents say. The Declaration of Helsinki, those of us working in the international and global health know that this has been a kind of benchmark for years. Now it's being revised with increasing frequency. The Declaration of Helsinki says, some research populations are particularly vulnerable and need special protection. These include those who cannot give or refuse consent for themselves and those who may be vulnerable to coercion or undue influence. So these are the two of the main criteria for the ethical acceptability of doing research, namely ability to consent and voluntariness with which you're participating. Well, this is too narrow and too brief, I claim. It doesn't say anything about what special protections are appropriate or necessary, so presumably that can be left up to the IRB. And let's assume we have really knowledgeable, good IRBs like you have here, so the IRB can determine what that is. But what are the specific features that determine the ability to give or refuse consent? Well, here, there's a lot of background and a lot of experience and a lot of precedent, because this can happen in clinical research in all kinds of circumstances and situations. So this is nothing new. What sort of coercion might be present? Well, that's an interesting one, because this is different from the typical clinical situation. The typical clinical situation is the worry that the clinician who is caring for the patient now takes off the clinician's hat, puts on the researcher's hat, and there you have your very own doctor asking you to be a research subject, which if you don't have the therapeutic misconception, or if you do have the therapeutic misconception, you might think is designed to serve your best interests. Well, here's another international document, the CIOM's International Ethical Guidelines for Biomedical Research. This is the 2002 document. And again, special justification. This one goes a little bit further. Before it even talks about special protections, the CIOM's guidelines say special justification is required for inviting vulnerable individuals to serve as research subjects, and if they're selected, the means of protecting their rights and welfare must be strictly applied. So it does talk about protections, but here it's the initial invitation. And what I suspect is that CIOMS, when it was prepared, was not thinking of disasters, but was thinking of the ordinary garden variety research. And here's their definition. Vulnerable persons are those who are relatively or absolutely incapable of protecting their own interests. More formally, they may have insufficient power, intelligence, education, resources, strength, or other needed attributes to protect their own interests. Well, this is now a tall order. If they lack several of those, then they're not going to be able to protect their own interest. And what does that mean? Does it mean that one should not seek to enroll them in research? Or can those lacks or deficits be met by these additional protections that the IRB is supposed to come up with? Another comment, actually, in CIOMS is they may have limited freedom to consent or to decline to participate in research. Now remember, these are general characteristics for vulnerable populations. So CIOMS doesn't just define it, now they give a list. And the typical way in most of the documents that talk about vulnerable populations in research is to provide a list. So let's take a look at the list. Subordinate members of hierarchical groups, elderly persons with dementia or residents of nursing homes. And notice that that can be two criteria or one. Elderly person with dementia, or residents of nursing home, or residents of nursing home with dementia. People receiving welfare benefits or social assistance. Well, that's going to cut out an increasingly large portion of the population in this country. Other poor people and the unemployed, millions. Patients in emergency rooms, some ethnic and racial minority groups, homeless persons, nomads. Remember, this is Sioms. I don't think we have many nomads here, but you know, nomads, refugees or displaced persons, prisoners, patients with, they go to California and get a lot of prisoners, patients with incurable disease, individuals who are politically powerless, well, I think that's most of us, members of communities unfamiliar with modern medical concepts. Well, when you put all these together, wait, do I have another? No mention of victim of disasters. No mention. Do I have one more? Yeah. Who isn't vulnerable then? Well, it seems when you read all these lists, and there are other lists and other documents, the only people who are not vulnerable are white men of substantial means from industrialized countries between the ages of 25 and 50. Everybody else is vulnerable. But now we come to a backlash against the overuse of the concept of vulnerability. And this claim, so many categories of people are now considered vulnerable that virtually all potential human subjects are included. And the question then is how to counter this skepticism and render the concept of vulnerability meaningful, if indeed it should be meaningful, if we want to continue to have concerns about the vulnerable in research, especially in the context of research in disasters. So, quick comparison with research involving patients. Before we conclude that this is all hopeless, I'm going to introduce an approach here that I didn't start with here, but there's a concept of layers of vulnerability, and I'm going to talk about that in a moment and give this example here. Investigations of new drugs or the experimental use of existing medications in disasters illustrates the idea that was put forward by one person in the literature, a bioethicist from Argentina, Florencia Luna, who wrote an article entitled "Layers, Not Labels." And here, what she's objecting to is the slapping on of a label on individuals or members of groups as vulnerable, and instead says, let's look at the context and layers as a relational concept. So she develops the idea of layers of vulnerability, and I'm applying it first here to the context of clinical research. Subjects are sick, injured, debilitated by exposure to toxic or lethal substances in any ordinary research, not limited to disasters. And a study involving medical or surgical intervention obviously carries some risk of harm and the possibility of adverse events that were not anticipated or unknown before the research. So in a disaster situation then, some of these unknowns and risks of whatever the intervention might be are no different in principle from a great deal of biomedical or clinical research. That is, we're not taking disaster research in isolation from what we already know about the risks and some of the ethical pitfalls, not only risks of harm, but possible intrusions on the rights of people. So when cases where patients may be severely ill or debilitated, or maybe coming into an emergency room with a head trauma, where one would argue that research is needed in order to improve the treatment of head trauma, you have some of the same circumstances or situations, but the scale is different and perhaps the severity is different. So here are some of the arguments about that what people have made. Well, it's okay if you do research on disasters if it occurs in an industrialized country, but in a developing country, governments are poor and possibly corrupt. Not that there's not corruption, again, in industrialized countries, but again, these are some of the arguments one sees. This is likely to be true, that is, among the population itself, that is, in hospitals or even in field situations, there are fewer skilled medical personnel than there are in industrialized countries, and so there's a shortage of which puts a greater burden on the personnel, and perhaps they have to work more quickly and maybe a little more inefficient given the constraints. Whenever there's a disaster in a developing country, poor countries and communities take longer to recover and to resume natural services. So one only has to look at Haiti, for example, which continues to suffer the consequences, and of course New Orleans, which some might argue never really fully recovered. And of course, then there's the question of the competition. The need for financial, medical, and other forms of aid should not be in competition with the conduct of research. And this again brings to mind what is needed in the emergency, again, is aid and not research, unless the research is also providing aid. But again, this is looked at as a competition of resources. If people who would normally be or are capable of being able to provide aid, medical aid, if they are devoting their time, their efforts, their energy, and perhaps their medical resources to conducting the research, if that takes away from the actual aid that they're supposed to be giving, then there's an ethical problem here. Some point out, however, this is a caveat, that the sources of research funding may differ from those from aid. So it's not always the case that resources, financial resources at least, are subtracted, or even personnel, human resources are subtracted from the humanitarian effort, the medical services. So I'm going to skip this because this is most people know about this, and I don't want to, we're near the end of the time. So the last few slides, very familiar to Nancy Cass because she's worked on this, is distinguishing disaster research from public health practice. You're going in there in a disaster and you're doing something to help people, and now you're doing research. How are you going to distinguish between them? Both research and public health response, we're talking now about public health response, whether it's usually by a government, but it could be humanitarian aid, both require gathering data from people caught in disasters. Even if you're doing a public health response that's not research, you gather information about people in order properly to mount your public health response. Both activities might involve blood drawing for detection of infection or radioactive material. Since whether you're, if you're going to treat people, you may have to draw blood. If you're going to do research, you may have to draw blood. Both situations could involve administering an antidote or medication and studying its effectiveness. Again, you may be studying it for research purposes, or you may already know that there is an antidote or something that would be efficacious, and so you want to bring that in. So these are similarities between the conduct of research and the public health practice of response to a disaster. Why do you have to distinguish between them then? Can't you just go ahead and do it? Well, now we go back to the requirements for research. Remember before we talked about the protocol? Well, if it's research, you have to submit the protocol for prior review by a duly constituted independent research ethics committee. That's the requirement. You have to obtain voluntary informed consent from research subjects or the research subject's legally authorized representative, of which there are very few except for parents. You have to explain the purpose, the procedures, the risks, the benefits, and the alternatives to participating. And if you ever looked at the CIOM's international guidelines, on their section, their guideline on informed consent, they've got 25 items that you've got to explain. By that time, the research subject's eyes have glazed over. Well, that's what you have to do if it's research, but if it's response to a disaster, that requires no prior committee review and no formal consent process. Well, there have been a variety of attempts to define research. We have the well-known definition in the U.S. Code of Federal Regulations, systematic investigation designed to develop or contribute to generalizable knowledge. That's the key, the generalizable knowledge. The CDC has the following distinction, which we know is sometimes difficult to apply. If the primary intent is to prevent or control disease or injury, or to improve public health program, and no research is intended at the present time, the project is non-research. Well, if we had a discussion here, and I'm going to finish up in 2 minutes, we would see the difficulty of trying to apply that. The criterion here is the primary intent. Well, one question is, how do you know whether intent is primary or secondary? And furthermore, whose intent? How do you ever know? Do I know the intention of anybody in this room? Intentions can be not easy to discern. Well, The problem with both of these definitions is what is learned in the course of the investigation may lead to generalizable knowledge, even if that was not the initial intent of the activity. And furthermore, intentions change. Response to a disaster may begin as a public health emergency response, but change to research as new information becomes available. A few additional problems. Emergency response often, in fact, contains elements of research in addition to the primary intent. There may be secondary activities gathering research. So, for example, a very common one, a questionnaire accompanied by drawing blood from people who become sick and those who remain well during a disease outbreak. This is a pretty important piece of information because you want to know, if you can discern it, why some people get sick and other people don't. And the only way to do that, that's not for the benefit of people during the research, but the only way to find this out would be by a questionnaire and possibly also a blood drawing or another physical examination. And researchers may seek to determine whether any biologic, genetic, or lifestyle factors caused some people to get sick while others did not. So if they now take a cheek swab and they have to start explaining to people that we're going to do genetic tests on this, imagine the difficulty of doing that informed consent during a disaster. So, possible solutions to this, not that this is a clear and obvious solution. IRBs could establish a policy for disease outbreak investigations, and that would include a short statement of purpose, and procedures of the investigation can be prepared and submitted for expedited review. So there can be a template, a sort of a general template that IRBs could develop. And the CIOM's EPI guidelines, the epidemiologic guidelines, which were issued in 2009, said best practice for research conducted during emergency is to establish the basic research design for various categories of research prior to the emergency. And if it's an organization like the World Health Organization or the CDC, which frequently responds for public health emergencies, but may also, as a response, public health response, but also conducts research, these organizations would be the prime ones to have that kind of protocol. So my conclusions, quickly, victims of disasters have a layer of vulnerability in addition to whatever other factors may make them vulnerable, and we saw what some of those might be at the beginning. But being vulnerable does not imply, or need not imply, that risks of research are any greater than for less vulnerable subjects. All the usual precautions should be in place to minimize risks, end an interview if it's too stressful, following a disaster, for example, and make provision for future medical care or counseling if needed. And these are also things that, always things that IRBs might consider as the additional protections for subjects. That's the last slide. Thank you.
We have time for a few questions. Ruth, are you?
We have 11 minutes. Yeah, I'll try to point to people. I know about 4 people by name, but I'll point to the others. Yes, please.
I'm Alan Dyer with the International Medical Corps, and I appreciate all of your remarks, and especially that you brought in this public health versus individual health, individual research question. And quickly trying to formulate my question about that. In international disaster work, we're looking at our M&E monitoring and evaluation processes on that very boundary that you were discussing between what is the intent to improve the health of the population, really in public health practice, and research questions which might come and be of interest in that. And so I guess the question that I want to ask you is, how do you draw that line between the interest in an individual who is at the same time a member of a population that you're also interested in?
Well, if it's for the monitoring and evaluation, you're basically, you may be asking questions, but you're also looking at records. And in that case, I think there's really no need to make that distinction because you would be doing the same thing for monitoring and evaluation as you would for research. You may use the results afterwards for research. But this situation of conducting research during a disaster there's always going to be attention to the individuals who are in need of treatment or care. And that would be a separate, that may require triage if it's a very severe disaster. And in that situation, I mean, that is moving people who couldn't benefit at all from those who don't need immediate care, the usual triage situations. And you're not going to be doing research in that context. So I guess we'd need, I mean, I hesitate to ask, but we'd need a specific example, because your general question is a good question, but I think this is the kind of example in ethics and other areas where you need an example to zero in and ask whether there's a conflict between the needs of the population or the needs of monitoring and evaluation and the needs of an individual. So if you have a clear example in mind, that might help.
There are several kinds of examples, and I'm not sure that there's one that really hones in on that concern that you just came back with. It seems to me that there's a kind of epistemological issue that's always at stake in terms of we're trying to apply what we understand to be the best practices, but it's not clear what the best practices necessarily are. And so when you look at the M&E part of that, you're trying to identify best practices when it isn't so much that the light is on or the light is off. This is a best practice, but that there are levels of evidence which are ambiguous in population.
Right. Well, I guess what I want to say just quickly to that is this may be a situation where you're not going to do research in a disaster. The best way, if you're questioning whether what your usual response is best practice, is to do some design and intervention study of some sort that can test the best practices. It's difficult for me to envisage how one could be doing that in the throes of a disaster situation. That is, the usual situation where you think you have something that's an improvement on best practices. You do your cluster randomization or communities or a setting like that. I don't see how you could begin to do that in the disaster without placing at risk a population when you're trying something new that may not be as good as the existing good practice, because it's all being implemented so fast. In the back, please.
Thank you. Thanks for the lecture. There's an argument made for substandard level of care in disaster settings. I was wondering if, if anything similar has been done for research in a disaster setting. Not that I'm advocating for substandard level of research ethics, but some people sometimes say that with urgent situations and stuff, maybe that might be a way of getting data quickly for the better of the population.
Well, we'd have to know in what ways it's substandard. Okay. Now, I mean, there may be something less than the best care. I mean, and this is an interesting question in the research setting, where the best care is not conceivably available. So if the best care requires building an ICU, an intensive care unit, not only can't you do that in a disaster, but you're not going to do that in a remote rural area of Malawi where you want to conduct some research that will provide benefits to the people that is less than the best available. And this is what's extremely important, especially about in a lot of developing countries that are poor or in very rural areas where you want to provide something that's better than nothing, but substandard means less than what you would be doing here at Hopkins in Baltimore. And certainly in a disaster situation, you may not have the kind of equipment. I mean, if it were required, the surgical fixation case that I mentioned is probably a good example. You're not going to have the ability to do the surgical fixation. If you did, if there's a nearby hospital and if the earthquake occurs right there, you might be able to do it. But so substandard, when you're comparing it to the best anywhere, but it's the only thing feasible or possible in the area, could be justified if it's better than nothing. And we need examples could show this better than anything else. Yes, please.
So I actually have an example dealing with your open fracture, because it kind of goes to his point as well about the idea of that standard of care. And if you're talking about standard of care here would be to try and get that closed up, cleaned up within 6 hours. If you're but you're not going to have too many people who are 12 hours, 2 days, like you can have following an earthquake. And so the question can be, what is best care? What is standard of care for a 2-day open wound, open femur fracture? And that actually does lead to the question, as a specific example of where, what is the best standard of care? And the question too is, what is the ethical choice for, can we randomize these individuals for something that we don't know much about?
Right.
We don't deal with 3-day-old open femur fractures really anymore.
Well, don't get me started on standard of care. It's one of the most used and least understood concepts with different meanings and different debate, but that's okay. I know what you're referring to. But I think we do have to, the debate here, as you describe it, should probably be between those who argue you have to randomize in order to get accurate results, and those who say sometimes you can loosen the strictures of methodology if it would be questionably ethical to force people to get something that they wouldn't choose. Now, I mean, the understanding of informed consent is people are supposed to understand randomization. They're supposed to be indifferent between or among the options. But if we're talking about what kinds of treatments to provide during a disaster, it's very likely that people are going to have some choice or other, especially if what's known is this is the better treatment, but this is quicker and more life-saving. So, I mean, we'd have to have a debate among methodologists and ethicists to ask whether or not you would really jeopardize the accuracy of the results that you would get if you do a trial and let people choose which treatment. Yes, in the back.
I just want to build up on that question. So there are a lot of studies going on right now about evaluating a hospital's preparedness for disaster response. So when disaster actually strikes, so a hospital says that I can take care of a certain number of patients with a certain standard of care. So does it match up when the disaster actually strikes? I mean, are these evaluations useful?
Well, so you're actually asking an empirical question to which I don't have the answer, but one would have to study it afterwards. That's a perfectly good research question. You've got the plan, now you get the disaster, and then afterwards you take a look to see whether it matches up. So your question is as good as mine, but obviously that has to be the follow-up. That has to be the follow-up. I'll only give one very quick example just to show that this is a real issue of the substandard or studying something that you don't know the answer to when there's no other option. And this is the study of a garment, a body garment that's used to prevent, that has not been adequately studied, and there have been different results in studies, that's used to stop postpartum hemorrhage. And in places where you don't have any blood transfusion equipment, that's the only thing, in other words, it's nothing, and the woman bleeds out and dies, or you do the garment, right? And that's substandard compared to a blood transfusion, but you can't do a blood transfusion because the equipment isn't there. The question that arises there is, should you use the garment on everyone if you don't know that it's effective, but you believe it's better than nothing, or do you randomize and you watch half the women hemorrhage and die, or some of the women hemorrhage and die? So it's another question that's a little bit harder here with the methodology, because you really don't know if the garment works. I guess we take one more question? Yes, please.
Can I follow up on the potential solution of having kind of a standard kind of ready to go for certain classes of care that you might provide? How does that work in a situation where you've got, I mean, if you're doing research, you've got one PI or maybe a couple of PIs. When you've got these disaster responses, you have resources coming from all over the place in different countries and different donors. And what's the idea of who would get that plan? Or, like, how would you decide, you know, if you're successful in charting out who's responsible for what anyway? Like, is the idea that everybody would use the same protocol, or can you just talk a little more about how that might work?
Well, look, that's a good question, but there are many variables you just mentioned, right? Not all the people who are coming to do research, right? But anyone who's coming to do research, and you're absolutely right, they come from all parts of the world. There was an Israeli team that went to Haiti. They were doing aid, not research. Maybe there was some research in there too, but they set up a field camp and did a huge amount of work in Haiti. But my assumption is, and I may be wrong, is that whatever group or team or country or unit is coming to do research will have its own protocol, and it's not likely to be a collaborative research effort. That is, because there are so many, there may be a Ministry of Health that's involved, there may be another government, there may be humanitarian organizations like MSF. So I would imagine that even though there may be a need for general research, that it would be almost impossible to coordinate, and especially because if there is no overall plan, you can't make an overall plan of a disaster that you don't know is going to happen. And once it happens, it's, act first and then think about planning later. So, but my guess is that any research that one would do, whether it's infectious disease research, wound care, or something like that, would be one team or one unit or one government sponsor. All right, Ruth said we finish at 1:15. It's 1:16, so I guess. Oh, yeah, I take this off, don't I? I'm not going to walk away with